We're going to be talking this afternoon on our hospital interventions. I'm going to introduce each speaker. I won't be introducing bios, but I can assure you that those that are speaking are ones that have done some work, and we're very proud of them, coming from our research team, from our office, and also across our LHDs as well. We'll be timing the presentation, so hopefully we can keep to time. And I'm just trying to see what's on that there. We've got our first presentation now. And I'd really like to welcome Paul Hudson, who's the Principal Lead Patient Safety Improvement Systems Director for us at the Clinical Excellence Commission. Very pleased to have Paul here as our manager as well. And he's going to talk to you how to use data to drive change and data for improvement. So thanks, Paul.
Thanks, Lorraine, and thank you for the opportunity to speak to you here today. I'll just make sure I will be able to use the clicker effectively. A couple of things. I suppose, like many of you in the room, ever since I started my career, there's a couple of things that's always sit in the back of my mind is we need to do the job. We need to actually make sure that we give our patients the treatments and the interventions that they require. But the other thing is, how do we do it better? How do we do it safer? And why is it, just because we've done it that way for so many years, why is that the best way? And how can we change that mentality? Because many of you in this room would enter your discipline and you would have gone the same thing. Question, why are you doing it that way? They taught us this way, and the current evidence and the research says that we should be doing this way, and the response is, that's just how we do it here. This is the way. And it's like, okay, big challenge there. And also, like many of you, there's also a personal interest of why this is important and improvement's important, but also falls and care of the elderly is important. On Sunday, I had the privilege of celebrating my grandmother's 95th birthday, which is a feat. She is a very strong-willed individual, has no filter, but has all her marbles, which is very entertaining in that respect. But just over 12 months ago, she did have a fall in her home, in her residence. She does live at home in that respect. She had a bit of a vasovagal associated with her medication review. GP was messing with her hypertensive medications. She sustained a nasty bump on the head and literally had the size of a tennis ball hematoma on her head and significant bruising. She also sustained a distal radius fracture and was admitted to one of our hospitals. And in my position, and I start hearing the story and start hearing it, and I start to cringe. And I'm going, oh, we could do this so much better. And you will do the same when I share a couple of things with you. She was in an area after leaving the ED, waiting to go to a ward, and we're thinking, we've got this history, 94 at that time, just had a fall, got a broken wrist, got a big head injury, right? And she needed to go to the toilet. And many of you are going to not be surprised that she was told, toilet's just down there, off you go. No support, no supervision, no support, no mobilisation. And it wasn't the clinician's fault. It's the system that sort of sets them up for that failure, and those blinkers of not understanding. When she did get to the ward, guess what? The first thing that she was handed, and it's really poignant because it was brought up in one of our last presentations. She was handed red socks. Put these on. They're going to help you not fall. No, that's not what it is. When I arrived, I told her, get rid of those socks and put your shoes on. The other thing she did, what was problem is there was no support with her toileting, noting that she couldn't get up from a chair because she had a broken wrist. And there was also no support with her nutritional needs because she couldn't open anything of there. And it's like, we must be able to do things better. And that's what drives me every day to come to work in my position. Now I'm going to talk to you about the most exciting topic that you've ever imagined, and it's data. Right? And it's perfect that it's just after lunch because then you're all set up to have a little nap. Hopefully we don't get there. But one thing that I keep thinking is, well, if only healthcare was this simple. If we just entered hospital and everything went fine, it was a direct line, and we were discharged. Life would be so perfect. But that's not our reality. Healthcare is delivered by humans. Humans make mistakes. Plus, it's in a complex system, multiple engagements, relationships, transports, everything. And it's actually more like this. There are multiple opportunities for errors. It's a weave of mess that we have to untangle. And we have to just, understand to describe. And the other thing is each system is different. Each hospital is different. Each ward in each hospital is different. And sometimes, depending on the ward, depending on the day, depending on the hour, the system is different, from business hours to afternoon out of hours to the weekend. And the perfect people to understand that system are the front line, because they live it, they breathe it, and they pick up on it. And it's now, how do we shift our thinking to go, how do we get that generational change where it actually starts from the ground and they identify it and move on? And how do we know that change is leading to an improvement? One of the only ways to do that is through data. But we also need to understand, how do we unpack this messiness of life in healthcare, and there needs to be some sort of methodology applied. And this is where we come to quality improvement methodologies. It doesn't really matter which one you apply. It really doesn't. And sometimes a combination of many is the best. But applying some sort of methodology helps you unpack and start off. And the other thing that we need to get over is we don't want to achieve any big jumps and big leaps, because they're impractical and almost impossible, and becomes ultimately overburdening, particularly when you have a busy ward and you just don't know where to start. The important thing is that you start and you just make small changes, small tests, and you make a way forward, because otherwise you're always just going to be falling back. So with the improvement methodology that CC sort of promotes, which is from HI Improvement Science, it's based on Deming's lens of profound knowledge. And this is applicable across many methodologies, and it's how you view your system through a different lens, and that we need to consider these items through it. Now, I'm going to give you a very quick rundown of these. All right, there is the safety essentials pathways that the CDC runs through the LHDs, that you can gain more information, and hopefully some of you have done the education, or you can just search it yourself. But it's when you look and consider your system through these lenses that it actually helps you to start to identify, where can I start and how do I know where I'm going. So we start just looking at appreciation of the system, actually understanding the system in its details and its intricacies. What it's like during the day, the months, what are the interactions, what are the comings and what are the goings, what are the peoples, what are the equipment, what is the environment, what are the triggers, what are our patient cohorts, what is the type? Because we already know in this room that we know that some patients, for example, in falls are going to fall. We did some work with a neuro ward that had a lot of brain injury cases, and it's not if they're going to fall, it's when they're going to fall. And having that appreciation that every system here is going to be different. The other thing is understanding variation data, which is what we're going to be talking about in most. But first of all, has anyone know what I mean by variation in data and understanding what normal variation is? Just put your hand up if you do. I don't need to. There's a couple. Good. All right. That is the sense that variation exists in our system. No one day is the same as the next day. Your falls incidences, the good and the bad will fluctuate, and they're within a boundary of what we call normal variation. And the importance of understanding that is looking at data over time, and I'll go through the importance of that very shortly. But first of all, just understanding it exists in our system, and that it, don't attribute credit or blame when there's dips and rises when it's just normal variation. Theory of knowledge. This comes into actually utilising your expertise within your system to predict if we do X, Y, and Z, it is likely to make a change. Right? Based on the research, based on the evidence, if we look at implementing or changing this in our work practices, we are likely to have this much impact. Applying that to your tests of change actually, allows you to learn more about your system. And sometimes learning what doesn't work is more important to learning what works for you. And one of the things within this methodology is test small, test quickly, fail early, right? Because it puts you on the path to where you're going to get your success. And then lastly, the other lens is the psychology of change, the human factor, the human interest. What is going to support that person to make their change, and understanding the framing at which people go through to make a decision that gets to their endpoint. Okay? How did they learn how to do something? What's their understanding of why we are doing an intervention? One of the things is, well, how do all these medication issues keep on happening? How do we make medication errors? If they follow the process, it should be fine. But no policy, no guideline counteracts for human and actually go, well, I've got X, Y, and Z going on, I've got buzzers going on, and I just need to hurry up and do it, and they miss the human factors and the human elements in that. Right? So understanding psychology of change, also change fatigue, particularly in your environments and whatnot, and just acceptance that you're always going to get naysayers. You're always going to get the people that go, no, this is what I do, this is how we do it, we're just going to do it, right? And the important thing is working with the ones that come on early, the ones that actually want to make change, which sometimes are more your junior staff. Utilising your naysayers to look at, well, changing that conversation. What would you do? This is not working. We can't keep doing the same thing. That's insanity. We're getting the same results every time. What would you change? Instead of being in the negative, let's try and flip it to a positive. So starting to view your system through these lenses can start to help identify where are my priorities going forward. Now, the other thing is you've got to be sensitive to the signals in your system about what's going on, right? It's not necessarily about the outcome. Sometimes it's about the outcome or whatnot, but the outcome is the product of the system itself. And you're only going to change, you've got to change the integrity, that messiness that we showed earlier, to actually change your outcome. Right? And so signals that you might get, and it might not be an IMS or it might not be a death and whatnot, but it might be, a case reviewed at M&M meeting. It might be a hack. It might be a hack data that you're reviewing. It might be a complaints or IMS, And sometimes your complaints, there's no adverse events on your patients, but there's things that have gone wrong or not as reliably delivered as what you would expect. Could just be a gut feeling, or it could be that nice executive conversation in the corridor where they go, what's the problem here? I think there might be a problem. I'm getting told this. What's going on? Now, when we're looking at quality improvement, it's really important that we actually delineate what the type of data we're looking at here, and that they are very key different types of data. So there's research data, and we've had some quite excellent research colleagues present their information, and that's very strict. It's all the data that you could possibly imagine. There's a fixed hypothesis that they work towards, and they're trying to answer a dedicated question. Right? Lots of rigour around it in that case. Then we've got data for judgment, which we're all going to be experienced with here, and that is, have you met your KPI? Have you done all your falls risk assessments? Because if you haven't done them all, how could you be safe? If you're not at 100%, I want to know why. Which actually has no impact on falls prevention whatsoever. But anyway, so there's that one. And then there's data for improvement. And data for improvement is, the easiest term is just enough data. It's just enough data to indicate that things are actually improving. That gives us the confidence that it's improving. It is not all the data in the world. It's not every single data that you can collect. It's what is feasible within your work time and your workspace to give you the confidence that you're moving in the right direction. If it's easily collected and you get everything, that's great. So EMR, coded data that can just be popped out through clicking a couple buttons, perfect. But a lot of the improvement data, it still needs to be manually collected because it's about observing, it's about looking at people. So just an indication of what we mean by the difference between data for improvement, data for judgment. The top one, and this is intentionally not a falls-related one, gives you the indication of a data for judgment. It's how many patients have been counselled for smoking cessation. It's a tick box exercise. Yep, I've done it. But how effective is that? We have no idea. That doesn't show us any quality improvement, any quality of care. Where the bottom one does, it shows the percentage of smokers who have not smoked for 2 months, which is increasing. So what's different about those interventions? Because the top one's not showing us anything. It's just saying, yep, cool, we're ticking a box. The bottom one is actually giving us a lot more information. The other important thing is that we're looking at data over time, and one of my biggest bear when I was back working within the LHD is that this was a common way that the executive liked their information. I want to know what you were like this quarter compared to last quarter, and if you're good, I'm going to give you a pat on the back. If you're bad, I'm going to ask for an action plan, for example. And this is what we commonly get. But when we look at data over time, this same data, and this is based on a real example, is this, which actually indicates there is no change, there is no benefit, no improvement, it's just normal variation within your system. So it's a very interesting trap that we can all fall in. But we've also got to explain it to our executives as well. Another example here, this is about a quality improvement. They did the same thing before and after change. This data can be represented in many different ways. And these are 5 different ways of how they're. The only chart there that indicates that the change actually led to an improvement is chart number 4. Chart number 1, apologise. Chart number 1, where the change happened, it dropped and kept going. Chart number 4, it did drop, but it went back. Okay? So be careful about what your data is telling you. Data over time is actually more effective going forward. The other thing is, how much data do we actually need? As I said to you, we don't need every single data point. In this one, you can actually identify that a change has led to improvement by looking at 5 to 10 notes in a time period. Why would we go to 20 and 50 when we're actually getting the same information? Again, this is not data for research. If we were doing data for research, we'd get everything. But this is data for improvement. It's got to be working within your system and be sustainable going on. So what if you got your data like this? What if you got your executive come up to you and gone, right, your falls have gone straight up, you're an outlier in the whole service, what are you doing? I want an action plan on my desk by 4 p.m, close the business tomorrow. A bit extreme, but probably not so much in some services. What are you going to do? Well, we do go through this data grief cycle. One of those is we go, no, that can't be our data. It's not happening. It's got to be wrong. You've got it wrong. There's got to be something wrong here. I'm going to go check the data and I'm going to make sure it's all clean. And sometimes it is, but most of the time it's correct. Then we go to an anger period. But I have all these systems. I've got all these policies in place. You've got to be following the policies and the procedures. Who's responsible? Why is it? I want to know what's happened on those shifts. That's another one. Then you go bargaining. Okay, no. It was just because we had a lot of agency staff that during that period. We got our normal staff back from leave. We got our C&E back. It's going to be back to normal now, and we're going to recover. It's all good. We don't need to put in a lot of work here. Then you get to depression. You actually realise it's actually none of those things. What went wrong? What did I miss? Because let's be honest, you're busy doing a whole lot of other things. What did you miss? And you start blaming everything. But it's actually not anyone's fault. It's just the system that is set up to do what it is. And then the last one is acceptance. Right, we've got to solve this problem. And how are we going to do it? So closing up, you're in a complex, very challenging system. When we start to unpack it, you need to do a deeper dive. Look at what you've got available, your monitoring, your medication reconciliation, your care planning, intentional rounding, your handover processes, your toileting, your mobilisation, your behaviour management. There are multiple factors that may impact your system, not all of them, but some of them, that will impact a change. Start somewhere and look at how that can improve. Do a deeper dive into understanding your issue for your system. And just remember, making sure the Deming's knowledge. So appreciation of the system, understanding that variation will exist, and we can go through the rules and whatnot with run charts and whatnot, but that's not for today. Theory of knowledge, and also your psychology of change. Starting small and getting the changes informed by your staff member is so powerful, because that is what's going to change that negative approach to this is how we've always done it, to actually positive one, where change is the reality of our system and we always change to always improve the care that we deliver. That's the norm. That's the goal. So just closing, just remember, when you do get presented with a single measure, look beyond it. It is not the be-all and end-all. It doesn't tell you the whole story. You need to understand and break down what are the processes that get to that end point. Where are we failing? Where are we not as reliable as what we could possibly be? Be careful to attribute blame or credit when it actually doesn't exist and it's just normal variation. Understand your system in more detail. It's just not about the data, but it's actually about being inquisitive, asking questions. Information comes in many forms. The stories from your patients, your relatives, your staff member are just as important as the actual quantitative data that you actually will get. And make time, even if it's just half an hour, 20 minutes, 15 minutes, to do a deeper dive into one aspect of your system and ask for help. You need to have a team that approaches this, not just a single person, because that's not sustainable. Thank you for your time, and just for those who are embarking on this journey or who haven't, please make sure that you visit the CDC website for comprehensive care and minimisation of harm. I'm sure Lorraine is advertising this. There's a huge wealth of resources there, ones that have just been released as a series of videos to support your education and the staff development in this area. So thank you very much.
Thank you, Paul. Does anyone have a question? We've got time for one question or two. No? No questions for Paul. And I know that some of you are on a journey in regards to this, and certainly there is information on our website in regards to how furthering understanding data for improvement. So we urge you to contact us if you're not sure, and we'll guide you to the right places to help you in little projects that you might be driving. And also reach out to people in your area, your local health district, who may well have already gone through the essentials pathway and are skilled already. So that's really important for you to know as well, to get support in any work that you might want to do.
Yep, and the team are always here to support with coaching through these aspects as well. All right, so please contact us.
Great.
Thanks.
Thanks, Paul. Our next presentation is from Charlotte McLennan, Protect, Fall Prevention Program, and Charlotte's the manager of that program from Sydney Local Health District, and she's going to talk about designing a hospital fall prevention program. Thanks, Charlotte.
Thanks, Lorraine, and thanks for this opportunity to present. So yes, I'm going to talk about designing a hospital fall prevention program, and I'm going to talk about a few projects we've undertaken in Sydney Local Health District, ultimately to inform our Protect Fall Prevention program, which we're hoping to kick off later this year. Sorry, I'll continue the vibe of the issue. Okay, there we go. So I'd just like to start by acknowledging, again, echoing this morning's acknowledgement of country, and pay my respects to traditional custodians of this land, the Gadigal people of the Eora Nation. So to start with a bit of a background, in 2022, Sydney Local Health District released a new fall prevention and management strategy, and the strategy was evidence-based, so it really emphasised education and multifactorial approaches to inpatient fall prevention, based largely on the 2018 Cameron-Cochrane review and the Morris et al. 2022 systematic review. But importantly, also, the strategy really acknowledged, as Paul mentioned, that we really need to consider that all wards have distinct needs and challenges, generally and in relation to fall prevention. And so the strategy really allowed for this and built in the ability for approaches to be tailored and flexible based on wards' unique needs and challenges. And so, as many here will know, it's all well and good to have a strategy, but how do we actually get that implemented into routine practice? And, how do we do that with fall prevention initiatives more broadly? And so we went to look at the implementation science literature, and that really pointed us to the need to really careful planning and implementing this strategy if we were going to implement it effectively and sustainably. And so the 3 programs I'm going to talk about, I cannot nail that buzzer. I'm going to cover 3 projects that then informed this careful planning. The first 2 I'm going to just touch on the results very briefly, and then the feasibility study I'm going to spend a little bit more time talking about. So the first project we undertook was an intervention component analysis, which is essentially a style of literature review where we looked at 37 randomised control trials of hospital fall prevention interventions. They were across a mix of settings and had a range of intervention types. And we wanted to work out, what are the critical features of these that are associated with success in these trials? And ultimately, 3 features emerged as appearing to impact the effectiveness of the fall prevention interventions. The first being integration of the activities with the local intervention setting. The second being interventions that were responsive to patients' needs and abilities, but also to population characteristics of where the intervention was rolling out. And finally, patient and family involvement. And I've starred the bottom 2 because they were the ones that appeared to have the greatest potential to impact the effectiveness. So our next study was a qualitative study where we spoke with staff, patients and family across hospitals in our district to work out, what are the considerations across these groups when implementing fall prevention programs? And what we had come out of these was 3 main themes. So the first takeaway was this overarching idea that all stakeholders agreed that fall prevention was an issue, that falls were an issue and that they needed to be prioritised. But there was a reluctance and inability at times for stakeholders to be able to prioritise it themselves and a tendency to focus on what others could do to prevent falls. And this was likely strongly linked to our second concept of stakeholders feeling quite disempowered when it came to implementing fall prevention, a little bit hopeless. And the smaller circles there represent what kind of fed into this, which was competing priorities, the complexity of the ever-changing acute hospital environment, workplace power relations between disciplines and between management and frontline staff, and unsurprisingly, workforce pressures, staffing ratios, and so forth. There was more positivity though, which we saw in theme 3, where shared responsibility really came out as a solution, and stakeholders were really optimistic when they talked about working together to implement fall prevention programs and identified 2 ways this might be more effectively done, A, through connecting across the care team, and B, through partnering with patients and families. And so with these 2 projects in our back pocket, we went about trying to test some strategies to enhance the implementation of our fall prevention strategy. And I'll preface by saying the aim of this project was really looking at the feasibility, the acceptability of what we did, rather than looking at whether we were making a big impact in falls reductions at this point. So we had 4 acute hospital wards that volunteered to participate in the program, and they were asked to nominate a team on their ward to implement the fall prevention strategy with guidance. We had a mix of 2 multidisciplinary teams and 2 nursing-only teams. The teams were to undergo improvement science training, which Paul has referenced there before, and there was the option to either do the online modules or a 2-day in-person course. And then the wards were supported with 12 weeks of very light touch, I will say, education and quality improvement coaching. It was provided by staff who had other substantive roles and was sort of on an as-needs weekly basis. We conducted pre and post surveys with staff on the wards involved and interviews with staff members involved in those key teams. And so here are some of the results of that feasibility program. The first thing to note is that we had 61 staff complete the pre-implementation surveys and just 35 complete the post, which is a lesson for us in that a lot of staff said when they went to do the post, because it was quite soon after doing the pre-survey and that the questions were quite similar, they thought they'd already done the survey. So that's a lesson for us to take away to make sure it's really obvious that this is a very different survey. But overall, I'll jump to the bottom point there. We had fairly average satisfaction. Well, the average satisfaction was 7.5 on a 1 to 10 scale, which, considering the program was quite light on, we were pretty happy with. And then we did see very subtle increases in some implementation domains that we looked at. So in terms of staff understanding their role in fall prevention, their confidence in implementing fall prevention activities, their ability to prevent falls, the frequency with which they were implementing fall prevention initiatives, and their local knowledge of their falls data had probably the biggest increase, which we were glad to see. We asked staff about what they perceived their barriers to implementing hospital fall prevention were, and unsurprisingly, time came out as the overwhelming barrier, which I think was almost to the detriment of people being able to think of anything else that might be a barrier. So, time was really it. We did have some responses in terms of, not knowing who to ask and not feeling confident and just remembering to implement fall prevention. In terms of what would help staff implement fall prevention programs, we had really diverse responses, which I think is unsurprising considering, staff have diverse needs and so forth. So, there was mixed responses, and education came out in a lot of them, wanting to know more about their local falls and having people to help with this. We then did some interviews with staff involved, and this was where we got some really deeper knowledge about what did and didn't work. And so there were 4 kind of key summaries that we've taken out of this. The first was how empowering improvement science training was, to Paul's point there, enabling staff to really use their local data to inform necessary and tailored change. And this was reflected on extremely positively by the staff that participated in the program. I will say there was a much greater preference for the face-to-face training than the 2-day course. There were some challenges with completing the online course within day-to-day work, but we had quotes such as this CNE talking about how they're constantly asked to engage in quality improvement but have never actually had any training until this point, and the ability that they could and the ability it gave them to then apply to other areas of their work. Our second takeaway was that the multidisciplinary approach to fall prevention was certainly favoured. It was what attracted people to participate in the program initially, but it was challenging at times. And to overcome this, what came out was a need for really clear value for all disciplines that were involved in the project and clear roles within the program. And so you can see physio there talking about that, they were attracted to the project because it was multidisciplinary, but then also staff reflecting on the challenges of multidisciplinary teamwork at times. So then our third takeaway was that staff really talked about they wanted a greater sense of momentum and accountability in the program. So, the idea of a little bit more of a nudge. The 12 weeks coaching that the staff were provided was quite light touch, as I've mentioned. So, there was that desire to create a bit more accountability, and they talked about, if there's all the competing demands and if they're not kind of given a little bit of more encouragement, it often gets taken over by something else, which marries in very well with our fourth takeaway, which was staff wanting this, being really grateful for their role in being able to design, and choose which strategies would suit their ward, but that they really did need expert direction and guidance with evidence-based practice to ensure what they were deciding was going to have an impact, and they reported that they would prefer to have had more of that than what was offered in our program. So what? With all of that, what we have done next is take away what we've learnt from those projects and from colleagues across other sites and more broadly. And we've designed what we've called the Protect Fall Prevention Program, which is prevention through education and coaching, which will see supported implementation, which is provided by the coaching and other tailored strategies of tailored fall prevention interventions guided by our local Sydney Local Health District Fall Prevention Strategy. So the key features will involve wards nominating a multidisciplinary team. We'll really emphasise still the multidisciplinary approach, and with executive sponsorship, hoping to garner a bit more of that accountability that they said they requested, and the wards can submit an EOI to participate. Wards will then, that team will then work with the Protect team to undergo a fall prevention needs analysis. So they'll look really closely at their local incident data, they'll collect patient and staff surveys, and there'll be that involvement of expert evidence-based fall prevention guidance to inform what change ideas might be most suitable on their ward. They'll attend the 2-day face-to-face quality improvement course, so we'll request at least 2 members of each team attend the face-to-face course, and then others can do the online training. And within that, we're going to embed some evidence-based practice for prevention components, and then there'll be 16 weeks of the more intensive coaching that will be provided by a dedicated role, and there'll be weekly tasks delegated and milestones. So this is also then being evaluated in a research trial, so and that's what's enabling the funding I should have mentioned through the National Health and Medical Research Council. And it's in a stepped wedge trial design, which I'm not going to go into now, but I can certainly speak more about later if anyone's interested. But we're hoping to roll that out in September, starting September this year. So I'd like to finish by acknowledging there have been so many people involved in this work. It's a real team collaborative effort. Very grateful to everyone involved. And yeah, thank you.
Thanks, Charlotte. Anyone have a question for Charlotte? Not at this point, but I'm sure there'll be lots of questions as this research unfolds, and we're really delighted to be partnering with you in this project as well, which is great. We could see it there anyway, Charlotte. Yeah. So thank you. We wish you well.
Thank you, Lorraine.
And we're very excited to see some improvement work being built into some research work as well in the nature of what we're doing. So I'd now like to welcome to the floor, and I should acknowledge all of those who are online virtually with us. I know that we've had over 100 this morning. I'm not sure how many are online with us here this afternoon, but we aren't ignoring you. We really value your input as well, and if you do have a question, if you wouldn't mind putting it in Slido, if you just put it into the Slido queue and just go hospital and then ask your question, and it'll come to us in this session, so thank you. So now I'd like to welcome to the floor Donna McCade from the Uniting War Memorial Hospital. And Donna's going to be talking about a multidisciplinary team approach to supporting older people with changed behaviours. Thank you, Donna.
Thank you. So yes, I'd like to talk about our approach to supporting our inpatients with changed behaviours. And I'd like to start with a case study that is likely not unfamiliar to all of you here. It's a recent inpatient at War Memorial Hospital, Mr. F, who is a man in his 70s diagnosed with Parkinson's disease. He was admitted to the hospital after recurrent falls and with deconditioning. And early on in his admission, staff were noticing that he was disoriented to time and place at night, and he was getting out of bed by himself, obviously increasing his falls risk, and wandering the hall trying to get home. And when staff intervened, he could escalate to aggression. So Mr. F is not uncommon to us at War Memorial Hospital. We're a subacute rehab hospital for older adults with an average patient age of 83.4 years. And they're often complex medical presentations combined with cognitive impairment, experiencing BPSD, and obviously at risk for delirium, falls, and other adverse events. Had Mr. F been in our hospital a couple of years ago, what would have happened is that as his behaviours escalated and escalated, he would have been referred to psychology, who would have got around to putting together a behaviour management plan, as we called it back then, after interviewing a couple of clinicians. And what's wrong with that is, A, it's really inefficient. Our psychologist only works part-time. And so by the time the psychologist is there, where have the behaviours got to? And B, it reinforces this message that behaviour support is some kind of black box mystery that only experts can manage. And it reinforces also this belief that we see in the literature that clinicians don't feel like they have the confidence or the ability to support people with changed behaviours, or challenging behaviours as they used to be called. So luckily for Mr F and a lot of other inpatients at War Memorial Hospital, we set about changing that. So what we did was we established a multidisciplinary project team of social work, physio, OT, speech pathology, and nursing and psychology, and we got together, reviewed best practice, reviewed academic best practice, and we put together a process which was underpinned by a person-centred model and a needs-driven model. Once we had that draft, we consulted widely with our dementia interest group at War Memorial Hospital, with clinical specialists in dementia, academic specialists. We also talked with people with the lived experience of dementia and their carers. And what we came up with was we refined our process to 3 steps. So as soon as changed behaviours emerge, nurses use the New South Wales Health 24-hour behaviour monitoring record form to really note the behaviour, understand the onset, intensity, frequency and so on, so we can really get a good picture of what's going on, but also the effectiveness of any strategies that they use. We also, once that information is there, we have daily safety huddles in which the team put together a specifically tailored behaviour support plan team for that person. So, the next stage after that is that team then creates a behaviour support plan. So what we did to roll out this process is that the multidisciplinary project team consulted widely and informed the organisation about our process, and we ran, as a multidisciplinary team, training for all inpatient clinicians about our new process, and we ran practical education sessions. We also created a resource guide. So this listed different scenarios of changed behaviours and what staff might find as the triggers and what strategies they can use. And on the slide here you can see a couple of examples of exit-seeking behaviour and falls risk and the sorts of triggers and strategies that we've put together in that scenario. And our resource guide also included proactive strategies that clinicians could use to prevent change behaviours and minimise falls risk. So back to Mr F, what happened? So remember Mr F, our man with Parkinson's disease. So in step 1, our nursing staff monitored his behaviour using the New South Wales behaviour monitoring form so we could understand what was going on. We brought that information to the safety huddle, who then brought together a team of the psychologist, the nurse and physiotherapist, and we sat together in step 3 with Mr F's wife and put together the behaviour support plan. We then communicated that widely and documented it and monitored it for its effectiveness and reviewed it as we went. Parallel to that, the doctors were obviously involved in terms of monitoring for delirium, and so that was a process going on in parallel. And so Mr F's behaviour support plan included information about him as a person, so understanding him as the person, so information from the sunflower and top 5. It described his behaviour. It looked at what the possible triggers that we could understand that were underlying the behaviour, and also looked at what the underlying needs were of that behaviour. So what was this behaviour trying to communicate to us that we needed to resolve? And what were the consequences of the behaviour? And his plan then had a list of strategies that we put together with his wife, that both his family and our clinicians could use to put in place to help keep him safe, stop him falling, and resolve the behaviours. So what happened? Well, this early intervention helped us to address Mr. F's situation and put in place some really good strategies that were based on what worked for him. And there were no adverse events, and Mr. F was discharged from the hospital in a much better state than when he came in, which is obviously our goal. We had positive feedback from Mrs. F, and she actually called the NUM and told the NUM about how much she appreciated the care and support that she'd received from the team. And Mrs. F had a copy of the plan so that she could continue to use that when he went home. So what's changed at War Memorial with our new behaviour support plan process? So since putting it in place in December 2022, we've seen a 250% increase in the behaviour support plans in place. And that's not because we've got a whole lot of dodgy patients. That is because we're just getting really better at the early identification of behaviours and putting in place individually tailored plans to support them. And in doing so, we've involved a range of clinicians. So it's not just the psychologists sitting in their ivory tower putting together a plan. It's actually involving nurses, occupational therapists, physiotherapists and social workers as an integral part of the team to develop, implement and monitor the plan. And we also put in place regular training and education sessions that were really practically based for staff to help build their confidence and give them the sense that they're able to contribute. And we actually saw that. So before the education, allied health and nursing clinicians' confidence in their ability to implement a behaviour support plan was only 31%. After the education, that rose to 61%. And before our education sessions, only 2% of allied health and nursing staff felt that they were able to create a behaviour support plan. And that rose to 32% after education. And it's our aim through regular education sessions to keep that number increasing. And we've had a focus on falls prevention. So one of the things that we looked at was how do we reduce falls. And we've seen a gradual trend down of falls. We've still got a lot of work to do. But we've started to focus on how our behaviour support plan can reduce falls on the ward. And so we ran some practical education sessions, workshopping scenarios of how we might approach different situations where falls risks were evident and what we could do as a team to minimise any adverse events. We also updated our resource guide with falls prevention strategies, and each clinician has a copy of this. And since March 2024, we've had more than 1 month's worth of days where we haven't had a fall on the ward. And that's the best result for us since we started collecting records. We still know we've got a lot of work to do though. So our key take-home messages from all of this is that by having this multidisciplinary approach, you can actually leverage the unique expertise, knowledge and experience of different clinicians to efficiently and effectively create a tailored behaviour support plan. And what this approach also does is encourage a mentoring opportunity for more experienced clinicians to buddy up with less experienced clinicians who they can learn for and build their confidence in creating behaviour support plans. Regular education sessions have helped staff also feel more confident, and we know that these ongoing communications really needed so that stakeholders, all of the stakeholders involved, use the language of falls prevention and behaviour support in everyday language. And we know that this is what is starting to happen at War Memorial Hospital. And unbeknownst to the project team, the nurses laminated a whole load of pages from our resource guide, which they actually pull out if there's a new patient that has a particular risk associated with them, puts them in the bedside folder and refers to them. So this year, the number of behaviour support plans we've had has actually gone down because hopefully we're getting to patients before behaviour escalates to being problematic. And we're incorporating the falls reduction strategies in our daily FRAMP for new admissions as well. So this is where all our processes tie in. And ultimately, it's our aim to make everyone feel that they can make a valuable and vital contribution to behaviour support, to reduce falls, and know that also they can involve families as an integral role in this process. So I'd like to acknowledge all of the team who were involved in setting up the behaviour support process with me, and thank you for your time.
Donna, thank you. It is such a critical area, really, and we're seeing more and more, or hearing more and more about patients who may have some behaviour changes while they're in our care, and how do we support our clinicians to be able to be more effective in managing them. So this is a great way forward, and I'm sure that there may well be any questions for Donna. Yes, we do have one. Come back, Donna.
Hi there. I'm just, my question is, I'd imagine these behaviour support plans were developed during the day when the staff are on, but these behaviours are typically exhibited at night time. How do you get around the challenges of communicating and managing these behaviours, and also getting sort of buy-in from the staff that typically work at night time to make them feel involved in the process?
Yeah, that's a really good point, because the doctors aren't on, they don't have, night staff don't have the resources that our day staff have, that's clear. One of the ways we're getting around that is just by upskilling the staff that work on night so that they feel more confident. We're also improving our communication process, so there's better handover of what's going on. And with the resource guide, we've got these strategies that they can first turn to, can this help? And often what we're doing is asking the family when patients are admitted, can our staff call you if you've got issues at night? And so we're finding that we're involving the family a lot more at night. We've got beds that we're setting up on the ward for family to stay in with patients to help settle them. But I agree, it's an ongoing challenge.
Right. Thank you. If there are no more questions, we might move on. Thank you. And thanks, Donna. I'm sure your address was on the bottom of your presentation. You may well have people following up with you as well in regards to your initiatives there. So I'd now like to welcome Greg Hays to the podium. Greg Hays is the Initiatives and Projects Coordinator for Excellence Nursing and Midwifery from Hunter, New England. And Greg's going to talk today about bringing it all together, Hunter, New England Falls Health Check, a multidisciplinary framework for the prevention of falls within the hospital. So thank you, Greg.
Thank you, everyone. Really interesting hearing all those presentations, because it's actually, it really resonates with a lot of the same problems that Hunter New England have as well. And I suppose the background around our Falls Health Check, is what we call it, was actually listening to Paul's presentation around being given data and then being asked to go into a service and support them. And one of the first things I've sort of always thought about is how do I do a deep dive? And this is, I suppose, Hunter New England's way of doing a bit of a deep dive and supporting the services. So in 2021, nursing midwifery services really started discussions on how we go into, engage and support these services in a non-punitive, consistent way that tied all aspects of falls prevention and management together. We recognised there's a huge amount of work going on, both internally and externally, from Hunter New England. So we made sure that, I suppose, how we first started it was around the appropriate language in that health check. And it really sort of relating to that process of empowering, engaging, examining, and forming recommendations in partnership with the service. So the very first version was just a one-page document that had 7 pillars, I suppose, for discussion, and it really sort of supported those facilitated conversations. And it was adopted by the Hunter New England Falls Governance Committee. I would like to acknowledge our executive sponsor, Elizabeth Grist, and also the nursing midwifery team, Sue Buckman, Michael Fay, Stephen Croft and Helen Baines. This did start as an idea, and I was lucky enough to work in a service where the ideas are very much encouraged and we can talk through and let it develop. And over 2 or 3 years, this is where we've now come to how we've developed version 2. So in late 2022, we actually went back and developed a version 2 of the Hunter New England's Falls Check. And it was a small working party, and the review really looked at what the scope of the Falls Health Check was, so what it is and what it wasn't, identified a really clear target audience, reviewed the headings and subheadings that we used to sort of facilitate those conversations. We developed a second page, adding a lot of additional information, actions, and also descriptions around how falls leads can utilise this resource. We added a 9th pillar, and it was really around that, making sure we include the patient. They are, after all, the centre, and very much better alignment with those national standards. We've added a template for completion, so we can also talk about and identify those opportunities for improvement, but also celebrating any success that the area may be doing well as well. And post this review and endorsement from the Falls Governance Committee, it was actually also adopted across the wider district from a clinical governance point of view, and very much saw it as a key tool that can be utilised in any investigation as well. So there it is, the Falls Health Check. I'm hoping the QR code at the top does work. It is unfortunately on SharePoint, so anyone who is outside of New South Wales Health, apologies, but you can take a photo of it as well. But this is the very first page. With it has the 9 pillars, or 8 pillars on the front, and also just a little bit of information around at the bottom around what the outcome looks like. But again, I suppose coming back to how and why this was developed, I was asked to go into a service to formulate recommendations of one-day visit and ask how I can help them. I had no idea where to start. I was new to the role. I was seen as a falls leads, and yes, I did have experience, but really it is a skill to go into a service and pull out what they need and how to help them as well. So the second page, and this is where it became a bit more autonomous for managers to use, the very first pillar that we look at is data. And I think Paul's aspect talked about it really well today. It's around understanding your data, knowing your trends, knowing not just your falls rate, but your falls with harm rate. Being mindful of that. We also integrate our safe toileting around unwitnessed falls in the bathrooms as well. We also encourage to go back and look at any previous investigations and whether those implementations or recommendations have been actually met, say 6 to 12 months previous as well. We log on to IMS Plus, check out any themes that are going on, not only from the time of falls, but also compare that from a district perspective. The second pillar dives into our compliance, so that looks at our PCPs, our hospital health pathways, our QAS audits and a few other things around national standards. The third one is how well we collaborate with the service, or the service collaborates, from whether it's team huddles, so who's included in the falls prevention team, how we involve medical officers, allied health, things like that, and also what communication looks like. The fourth one is our excellence, so our evidence-based sort of engagement with partners. A lot of that is around our framework from our essential elements of patient care that we do have, that also many are supported by the CEC. Fifth one sits around awareness, typically sometimes April Falls, what that looks like, how that's measured, how we engage, and whether that looks at a district or a local service as well. The second last one's around the equipment and environment, so having a look at the environment that they've got to work with, the equipment that they're using and how it's being used, plus the model of care. And then the final one sits with staff and leadership, so that culture aspect as well. I'm going to just quickly throw in a few examples of how we've applied this. So this first example is actually a medical and rehabilitation ward at a larger hospital. So recognition that the NUM, CNC and Falls lead were involved, and the reason it happened was because the Falls Governance Committee asked for a bit of a review, and also local management asked for support. So the outcome was 3 Teams meetings and 1 on-site meeting, with it ended up being a 1-page brief with some appendix around data, what was discussed, things like that. You can see on the right-hand side the template that's used to encourage. It's about just forming dot points and letting the recommendations naturally form throughout the process. What resulted was actually this project, because it turned into a quality improvement project, was presented at the Falls Forum this year. They actually had a 43% reduction in falls. The actual project aimed for a 20, but it ended up having a 43, which is a great outcome. And they also had no falls with harm over the 6-month implementation phase. So how that looked from a documentation point of view, there's your recommendations. We tried to keep it simple with 3 and then adding some additional things underneath. So the first one was actually looking at the brief and talking around what things we wanted to celebrate, but also those areas for improvement. The second one was a back to basic project with a 6-month time frame. And then the third one was around actually moving away from having a problem to leading the way and doing that quality improvement project. How we sometimes write it up, this is the appendix example, so this is just the data version of it. So you can see there's a celebrate success around unwitnessed falls, a reduction in the bathroom over a couple of years, but there's also some identified opportunities sitting in there, particularly with falls with harm, which again was why the referral occurred. The second example was around a medical inpatient in a rural facility with the HSM, NUM1 and falls lead involved. So this is, again, a higher than expected falls rate. Please go in and support the service, and the HSM actually reached out to us. It was a little bit, I suppose, less in depth compared to the previous example. There was a Teams meeting and also an on-site visit as well, and it was actually the result of just an ISBAR email using the headings. Looking at those results and the visit, you can see that from a per 1,000 patient days, it went from 11.8 down to 5.1 and then has been maintained to 5.4, or you've got the average per month there because it is a smaller facility. Writing up the excellence, I suppose, pillar, looked at just your hourly rounding, your safety huddles and your clinical handover, again celebrating some successes to take back to the team, but also identifying those opportunities that you want to action as well. You can see some recommendations, but interestingly, I think what actually led this one to being very successful was the safety huddle. And as you know, that's a building block for a safe ward. It wasn't only just they did have the safety huddle, but the staff went away from the safety huddle having no idea it was a lot of white noise. So it was actually really having an effective safety huddle. And I think actually that is one of the main reasons this one was so successful, was the recommendation of reworking the safety huddle. And the third and final one that I'll talk about is actually a proactive approach from an MPS service. Again, recognising allied health hadn't been involved in a few of them that I had attended, and it's really important to have that MDT approach. So we got those guys involved as well. Again, 3 Teams meetings, an on-site visit, ended up a 1-page brief with, again, information in the appendix. The result, because they didn't have an issue with falls, or an identified issue anyway, it was actually more about the nurse unit manager who was new to the role and upskilling. So that's anything from quids to understanding, because they were from an external, a private facility, so they were very new to Hunter New England as well. And it was around that clear focus areas for improvement and also an opportunity to change things. And ultimately maintaining that safe clinical space, recognising that clinical and that senior leadership had changed. So again, you can see the recommendations and how the policies and procedures column was written up. The QAS audits there, again, we've got our 3 within Hunter New England. You can see that from an observational, there was a good celebrate success, the ward was safe, but from a documentation and also a post-fall audit, there was a few options for improvement as well. And their recommendations, again, talked about the safety huddle, the April Falls campaign, and also their individual model of care that they can action as well. So future opportunities identified. So I think for our team, it's very much being true to the Falls Health Check's name in the sense of making sure it continues to be and enhance that MDT members approach. Really being mindful to, because I am a nurse, to always include that allied health and medical. There's always room for improvement and space for updates, and it's really important to keep resources contemporary and promote the resource as well. The health check idea, I suppose, or that aspect can actually be transferable to many aspects of our system. It could be pressure injuries as well, but it is that opportunity for facilitated discussion, that partnership, and that development of those recommendations with timeframes, accountability, and responsibilities. Due to the success of Hunter New England's Falls Health Check, and I suppose a good actionable thing that we are able to talk about with Falls, if there is a problem or if there is something we wanted to be proactive about, the district has actually developed a comprehensive care version of it as well. And this really is around supporting facilities and services to help align with the actual national standard, because it can get quite overwhelming at times. Thank you.
Don't run away, there might be a question. Any questions from the floor for Greg? No? Greg, I think this actually is very interesting, and I'm intrigued to see that you're actually moving now to comprehensive care, because we as a team have talked about what's the framework that we can build to support the work that we do around the model. So we maybe will be liaising with you in regards to that. So I thank you for taking the lead and giving that big overview picture about how you can actually go into a service and look where the strengths are, but where the opportunities are for improvement. So congratulations, and we encourage you in the next phase of this work so that we might be able to work with you and learn from you as well. Thank you.
Thank you.
Thank you. Our next speaker is Svetlana and Erin are from Wollongong Hospital. Svetlana is the nurse unit manager, and Erin, you're the clinical nurse educator. Have I got that right as to how that's done? Excellent, thank you. We really welcome you. So they're going to talk about a really interesting project. I'm sure it's going to be stir up a lot of interest with you as well. And it's around close observation of patients at risk of clinical deterioration and falls with the use of CCTV. So thank you, Svetlana.
Thank you, Lorraine. Thank you for inviting us as well. Okay, where did we start? So first we'll talk about how we started with what we're doing. So just to talk about a bit about our team and our facilities. So we're from Wollongong Hospital, which is the Illawarra Chalhaven Local Health District. We initially was an acute medical ward, branching from 2020, and then we're relocated to a surgical purpose-built ward due to COVID. The ward layout was quite challenging. There was 15 single rooms, multiple double rooms, and it was a quite large floor space as well. We were required to care for patients that were suspected or positive for COVID-19, and all patients were isolated until proved they were confirmed whether they had COVID or not, and obviously remained isolated if they had COVID during the period of their hospital stay. This proved nursing to be quite difficult, as we know it, because we like to be at the bedside of our patients. The doors needed to remain closed, so we were unable to visualise our patients, which was very difficult. Also, we had this perception that PPE might run out. It was a time when there was quite a bit of fear, and really at that time also we had limited to no visitors allowed, one due to government state lockdowns, as well as hospital rules in terms of visitation. So initially it was a very uncertain time, and we needed contact needed to be somehow minimised without detriment to patient care. we recognised a major gap in patients having contact with also their loved ones, which caused quite concern for everybody, not just their loved ones, the patients, but also for us as nurses. We involved consumers. We recognised that this time was where we even more greater needed to involve our consumers because they weren't there present, so we needed to make that increased contact with them. And while we were doing this, so we were providing daily updates about their loved ones and their condition because there was no visitation. During this period of time, what we noticed, the gap was that they were, one, worried about their loved one being monitored. How were we monitoring them with the doors closed? They weren't there to see what kind of care we were providing for them. And also they weren't often able to have that contact with their loved one. So what we did, we seen that there was quite a big gap here in our system. We went out with our IT department who assisted us to find a system that, one, helped with communicating patients with their loved ones, as well as us communicating with the patients at a greater multi-dip level where, again, people were limited to coming into our ward. So what we had was we facilitated also those daily phone calls with the patients. Initially what we found was we went out and we found this system called the Roland Cockpit system. However, that aided in more so the communication between patient and the healthcare worker. But we also knew that we needed a device where we were able to monitor our patients closely in terms of that eyes on patients, which was limited. We recognised that patients deteriorated very quickly with COVID-19, coming in requiring no oxygen to requiring high flow 60-60 and needing to go to ICU tube. So it was a very quick period in which patients deteriorated and we needed eyes on patients. So what we did was we worked with the company as well as our IT department, and we initially installed in February 2022 13 cameras alongside the cockpit system, and they're pretty much CCTV cameras as you see within any area. And we initially installed those into the 5 single rooms on the ward, and then also into the double bedded rooms, which is where we mainly housed our patients with either suspected or confirmed COVID. And these rooms were prioritised for these patients. So, however, we then seen an increased community transmission of COVID-19, which greatly impacted our older community. So while we initially went out and bought these cameras to ensure we monitored our patients with COVID-19, we recognised that with the spread of COVID into our community, as well as our nursing homes and our acute geriatric units, we found that we had more patients on our ward that were elderly and which also had delirium as well as a result of the COVID. There were some other things that also resulted from COVID, which was syncope, as well as postural hypotension and that orthostatic hypertension, because they also had, unfortunately, vomiting and diarrhoea, which we've seen in some of the strains. So what did we do? We actually had data to demonstrate the effectiveness of the cameras, particularly in these rooms. And what we did was we were able to acquire funding once more again to install the additional 22 cameras, because initially we were at a reduced capacity, so we were only looking at, there wasn't as much COVID within our local health district, but with the greater transmission and assisting other local health districts as well, we were at capacity. So in terms of monitoring with the CCTV cameras, I'll pass you over to Erin.
Yeah, so now we essentially have 35 patient bed spaces that are monitored via CCTV cameras, so we're extremely lucky to find ourselves in, to have those resources available to us. So we had to figure out how we were going to monitor them now. So staff were designated and trained to monitor the cameras and alert nursing staff when they saw that a patient was potentially going to get out of bed, and that was from 7 a.m. till 10 p.m, 7 days a week. Obviously, patient privacy and dignity remained to be extremely important to us, as it's important to the patients as well. So these cameras that we had, they were actually able to be turned on and off. You can move the cameras all around the room. So if the patient wasn't in their bed space, you can actually point the camera to maybe sitting in the chair.
And nursing staff also informed the person that was monitoring the cameras that they might be doing something that was a bit more private, so it was best that they turn the cameras off. So we recognise that these staff played an important role in keeping our patients safe and assisting clinicians on the floor to intervene quickly when a patient was at risk of falls. So the designated staff that we had to monitor the cameras did find it challenging to monitor all 35, and I'll show you in the next slide how that looks. So we had to come up, our monitoring process was strong, but we had to implement additional strategies to ensure that we were monitoring the patients that needed to be. So this is a view of what we see through the CCTV camera. So this is an example. This is a screenshot of what it looks like when you're monitoring just 13 patients. So as you can imagine, if you have 35 patients up on that screen, it's going to be extremely difficult to keep a close eye on them. So what did we do? So we continued to use the CCTV cameras alongside our our standard strategies. So we continued to use the OMS falls risk screen, our standard tool. We utilised the 4AT and the falls prevention plan. So we had our standard strategies that we'd utilise, such as the claw bell and reach, mobility aids, appropriate footwear. That all continued. We developed a risk assessment tool for the use of the CCTV cameras for monitoring, and that's within our nursing documentation, which I'll also show you. We changed sensor mat brands as well. So we had a look through some literature, and CCTV monitoring alone wasn't effective on its own. So we looked at sensor mats and low beds to use those to complement the use of the CCTV monitoring. And we've also developed a risk assessment tool, because things like sensor mats and low beds, they're not always readily available for all of our patients. So we have to really be prioritising the patients we're choosing to use those for. So how did we develop these risk assessments? So we reviewed the existing policy that our district had on the use of low beds. Our risk assessment sort of aligned with the policy requirements. We, as I said, looked at literature based on sensor mats and low beds. We reviewed our own departmental IAMS data and post-fall safety huddles, where we identified common themes and including the mechanisms and reasons that the patients were falling. And we also had questions about how consent around this CCTV monitoring was going to be captured and recorded. So this is just a small section of our nursing documentation. So we talk a bit about our low beds, sensor mats and CCTV monitoring. The first three boxes are our risk assessment. So it talks about whether the patient's impulsive, are they non-compliant with their buzzer, are they attempting to climb out of bed? So there's a couple of different options there which we consider, and whether the patient meets that criteria would be whether we implement those strategies. So sometimes we're using CCTV monitoring alone, and that's effective, but for some patients, if they're impulsive, we can't get to them quick enough, we utilise sensor mats and low beds alongside the CCTV. We have also down the bottom, this is how we capture our consent. So if our patient's able to consent, we'll have a discussion with them on admission to the ward. We'll provide them with information about the CCTV monitoring. It's also uploaded on our district patient information portal, and we provide the patients with a handout on admission to the ward which talks about the CCTV monitoring. If the patient isn't able to provide consent themselves, we will speak with their person responsible to gain substitute consent for that. And if they're culturally and linguistically diverse, we will ensure that we utilise an interpreter, the same as we would for any other sort of risk assessment. Once our nursing staff identify that a patient needs to be on this CCTV CCTV monitoring. We wanted to come up with a process to ensure that this was communicated amongst our team. So this here is an example of our safety huddle. So this is shift to shift. So we work 12-hour shifts. So at 7 a.m. and 7 p.m, the nurse in charge will read this out to the oncoming shift, and this has the patient's bed number, their name. Their name's important because beds are often moving, and then their reason for being on CCTV monitoring. So Svetlana mentioned that it wasn't just for falls risk, it's also for some patients. Like we found the value in using the monitoring to identify clinical deterioration. So some patients are on it for that. So we say why they're on it. And here's a little bit about what we've been able to identify.
So I think just to point out, Erin and I are nurses, not statisticians. However, we did capture some really interesting data. So pre-CCTV, we'll just give you a 3-month snapshot. We had 20 falls between November 21 to January 2022. And this is when we're actually at reduced capacity. So all of our 35 beds were not full. So based on data, we actually collected data for a 1-year period, and I knew that we were going to capture quite interesting data and quite eye-catching, but I think once we looked at it as a whole, later it was quite confronting as to how we kept our patients safe while they were with us in hospital. So in December 2022, we had recorded that at 510 times a nurse needed to intervene to stop a patient potentially from falling over. And what we've seen was we had 3 patients fall. One was witnessed, and that witness fall patient was on CCTV camera. They had COVID, and the nurse recognised that they needed to go in. They were donning, and the patient fell. Saying that, yes, the patient did fall, but they were not on the floor for a long period of time at all. And it wasn't about, when did the fall happen. We knew how it happened, when it happened, and we were able to get to the patient to provide them their care. The 2 other falls that actually occurred were patients that were not high falls risk patients, and the falls risk assessment was true and accurate. Also, March 2023, we've seen 735 staff interventions with 2 falls that were actually witnessed. And then in April 2023, we had 698 nurse interventions with 0 falls. Now, what we have seen is we continue to see these excellent results in terms of helping our patients stay safe, and we see increased staff satisfaction as well. So it's not just within our patients and their families, but also within our nursing team. So other important points to take home is that the CCTV doesn't actually record. So we are not governed by legislation in terms of record keeping. So what you see is what you get, and once it passes, it's passed. We also have signage for persons entering the ward. We've involved consumers within that. So what does that signage look like? It's once you enter the ward, and also near every patient, My Health Care Board. It doesn't reduce the therapeutic interactions between the patients and the staff, because we still do intentional rounding, we still do point of care nursing, toileting regimes. So this is to complement what we do. And again, it's governed by the Human Rights Charter and Surveillance Devices Act. And we've also got a local policy which we've developed and continually evolving as we're seeing changes, which has been mentioned within any development of practice.
That's it.
That's it from us. It was a very quick nutshell.
Does anyone have any questions? No? Yes? Charlotte has one.
Thanks, guys, for your presentation. Sorry, I might have missed this, but in terms of you saying the staff that monitored the CCTV, so exactly who were they, and then what was the communication process then to the frontline staff?
Thank you. So initially, we had employed staff to assist us with communicating, so to run those phone calls between the patients and their family, as well as taking orders in terms of meals because HealthShare would not go into patients' rooms to take their orders. So we wanted to make sure that patients did not miss out on the other things that they would get in the other on the other wards. So what we actually noticed was that the camera usage was when the incidence of COVID exploded. What we've seen was there was a reduced staffing. And we needed to strategically employ people that were interested to come within our ward, and those people were employed within that admin role. However, they were staff that had some sort of healthcare training background. So it was people undergoing their physiotherapy training or nursing. So they understood what the goal was, and they were trained also on coming to the ward. We monitor the cameras now, so unfortunately I think that COVID funding has diminished. So the way we do it is, as Erin said, communication is essential, and we need to make sure falls is everybody's business. So we include our admin staff, our physios, our OTs, myself, Erin, our CSO, and particularly in busy periods of time, we share the monitoring of the cameras and what it looks like when you alert the staff member. So back in the days with COVID, the person that was hired to be monitoring the camera, particularly that 7 to 10 p.m, anybody that was nearby in terms of nursing, they would alert them and which patient it was that was getting up out of bed.
I think just to add on to what Svets had to say is everyone really feels, we're really grateful to work in an area where everyone just feels like a collective responsibility to keep patients safe. So no matter the role and what they're employed to do, everyone just feels that we're so, keep them safe. So we're very lucky.
There's another question up there.
Thanks for the explanation. That was one of my questions. My other question was, in your data, what were the staff interventions? How did you measure that?
Yeah. So what we did was when the staff members were involved also in our group huddles, in our team huddles, so they would capture which patients were required to be on camera. And then I knew that the data was going to be interesting. So every time they needed to notify a nurse to intervene with the patient, they would actually record it as a strike. Sorry? Correct. They were all pretty much near misses. Yeah. So every time the nurse actually needed to intervene, that was a near miss. Yeah. Yeah, thank you.
Thank you so much. I think it's really, it's using innovation, and I'm sure that in time it may be something that we'll move to more completely. But one of the things you've just said, and I guess it comes to your leadership as well on the ward, is how you get ward engagement with everyone, seeing it as their business. So I congratulate you on that, because I really think that's the start, isn't it? To support one another and to encourage one another and to be sharing the care. But it was also good to hear that you're doing the safety huddles and intentional rounding. You're not just relying on the cameras to show you, you actually have to do the work as well to support it. So well done. Thank you very much for that. Thank you. So our final presentation this afternoon is from Preetika Narayan from Braeside Hospital, South Western Sydney Local Health District. Preetika is going to talk about Don't Fall For It. So welcome. We look forward to hearing Don't Fall For It.
He'll be my co-presenter. I'll introduce myself. I am not Preetika. My name is Bill and I'll be Preetika's co-presenter.
Hi everyone. My name is Preetika. I'm the nurse educator for Braeside Hospital. And Billy is the NUM of the rehabilitation and he'll be my co-presenter.
Good afternoon, everyone. Don't fall for it, Preetika. That is the name of our presentation and our project. Do you like our name?
Yes.
Yes, me too. Maybe because we're biased and we're the ones who came up with it. But Preetika, do you want to introduce our team?
Okay. So Braeside Hospital. So Braeside Hospital is under Harman Care. We are New South Wales Health affiliate organisation. So we co-share patients with South Western Sydney Local Health District. We are sub-acute facility with 36 beds located near Fairfield District Hospital.
And with this particular project, who are our members?
So 2 of us are here and 1 of our members is present in here. However, I'm acknowledging other members and my multidisciplinary team members who contributed to make this project successful.
We do take a lot of pride in saying that this is a true MDT engagement. We had a lot of change in membership, including myself, because our previous NUM was the original member, but we've kept it an MDT approach. Preetika, why did we start this project in the first place?
Okay. So we did start this project. In year 2022, we had an increased number of falls. So increased number of falls, we had 76 falls, and average fall was 7 to 9 falls average per month. We also had 1 harm score, which resulted in a fracture. So our data also records at district level as well. So usual practice we were using was not reducing the falls. So I reached out to the district, thought to explore more if they were doing something different. It happened to be I got invited to attend a 2-day improvement workshop, which we went with our team. So we went for, one of them were Allied Health, OT and PT and the NUM, previous NUM, and myself. So when I came back, we engaged more, and then we were extremely delighted, so we wanted to commence this project.
Great. So basically, we got some help. Now, what was the project aim?
So the project aim was 50% reduction in falls in incidents and 0 HS2 by February 2022 using the improvement science methodology.
Right. Now we've got a plan. How did we get started?
So we did a survey, MDT survey. So we did the MDT survey and we found that we had a gap in communication and gap in awareness. So awareness, so what we did, awareness was we introduced our falls safety cross, and communication, we implemented a risk huddle.
Right. Those are great names, Preetika. But what is falls safety cross?
A falls safety cross is a calendar where we mark the days when we have falls. So the most important part was that we placed this falls safety cross outside our clinical practice unit, and not only the staff members got empowered to participate to cross the falls days of the month, also the family members started participating it, which was great, and all the MDT members started contributing, and the family members as well.
We actually have some photos there. That's the photo of the calendar, the falls safety cross. I remember a family member constantly asking us about what that is. So I'd take that as a win. How about the risk huddle, Preetika?
A risk huddle is a short huddle before a clinical handover to flag a risk for every staff member is aware of the commencement of the shift. This is already a common practice at the district level. For Brightside Hospital, this was a new practice because we are standalone facility, so we're limited in resources. So we had to actually explore those resources from the district. So what was the result of this project?
Now, my turn. This is our graph. Basically, the line in the middle is our average falls per month before the project. We started our project on February 2022. Most of the time, we've had falls incident for a month that is below average, but we did have some spikes. Now, we are being careful here not to attribute credit or blame, because there could be variation to the data as per poll. But we did note that in some instances, which are those 3 boxes there, we saw some interesting incidences that happened at the same time. So we had some severe staffing issue at around June 2023, where a lot of our staff members have moved on, and we had to recruit, but we had to wait because our sister hospital has closed down and we have to absorb their staff members. There was a transition period and we had to wait for a couple months, and in those couple months we had to employ more casual and agency staff. The second spike, which is the highest there, is a recurrent faller patient who's severely skewed data. But this patient has actually fallen so many times that at the safety huddle, our conversation was around, okay, how are we going to prevent this fall today? And we've ended up buying a helmet for this patient.
Yes, I ended up going myself to buy the safety helmet for the patient to reduce the injury.
At that time, we bought a helmet from Kmart. We were not aware that there was a dedicated helmet used by the neuro wards. But our colleagues in the district kindly informed us that in our last presentation. Now, Preetika, after all that talk, did we achieve our goal?
Yes, we did. So, zero harm score 2. There was no zero harm. We reached to zero harm score 2, so we were able to reduce our falls rate from 8.5 falls per 1,000 occupied bed to 3.9 at the end of the project. So we did achieve our result. So
now, Preetika, we have a last slide.
It's not working.
But basically,
so
where to next is our last slide. Further implementation.
Further implementation, so we introduced a care board, patient care board, which we adopted some resources from the district. Also, we identified champions for every shift, for morning, afternoon, and night shift. And we also now introduced our in-house cure mats, sensor mats, which is attached to our nurse call buzzer.
Just to add on what Preetika said, our interventions are also adopted by our sister ward in the same hospital. The palliative care ward has also adopted some of our strategies. And that concludes our presentation. Thank you.
Any questions?
Thank you. Does anyone have a question? Paul, I'm sure you're delighted to see an improvement project there with some data and a driver diagram and the process map. Do you have a comment to make?
That was a very, very good improvement science presentation. Well done. And I know exactly who has taught you in that because I taught them that. So it's very nice that that has been continued on. And as I think the biggest message here, you can tell that their data told a story. So when they had their spikes, it wasn't, oh, it's just a spike. It's things they actually went and actually understood what that spike meant, what interventions can we do, what does that mean for our system. And, you know, with falls and the patient cohorts, their own individual system, a recurrent faller, as you all know, is exceedingly challenging. And the approach of how can we prevent the fall today, because you know they're going to fall, but also how can we reduce their injury as well. So I commend, all the presentations. It's been a very beneficial sessions. Thank you.
Yeah, thank you. And just wanted to just ask, that person that fell multiple times and you actually did your own creative work to try and find a helmet, did he sustain or she sustain any injury at any time during that time?
He didn't. So he was in a close observation unit, room near the nurse. Close observation to the nurse's station, and every 30 minutes we had an intentional rounding, plus he was wearing the helmet.
Great, thank you. And Preetika and Billy, thank you for your entertaining presentation, but a valuable one where we could see improvement science working, so congratulate you both on that. Thank you. So this draws us to an end to this afternoon's session. I'm really encouraged by the differences of the things that we've seen today, things that we can learn from, and I do encourage you to learn and follow up from those things that you might be interested in from what you've heard today. Follow up with the presenters if you can and would like to, and certainly we'd be available at the CEC to support you as well if you've got other questions that we haven't quite answered today. We will be putting all these presentations up on the New South Wales Fall Prevention and Healthy Ageing Network. We'll give advice as to when that's ready and when that's available for you as well, because sometimes it's good to go back over a presentation with some details that you might miss.